Welcome back. It's nice to be with you again for lecture 2 in our series on nursing informatics. Thanks for those of you who went to Moodle and filled out the feedback questions that I had asked. I looked them over and appreciate what you said. I'm going to start by sharing my screen, and we'll jump right into the goals for today. Those goals include using healthcare informatics to improve healthcare delivery and outcomes, quality improvement initiatives, and the role of the electronic health record in healthcare. So it's a good bit to cover. We'll do our best. I'm going to start off with using healthcare informatics to improve care delivery and outcomes. Organizations use data strategically in 3 ways: to make sense of what's happening in their environment, to create knowledge, and to make decisions about what actions to take. We're going to start right away with a video that comes from British Columbia, and it is part of a 3-part series. We're seeing the 3rd in the series, which is measurement and using data for improvement.
Hello, and welcome to the BC Patient Safety Quality Council Learning Series on Improvement Topics. This is Module 3, Measurement and Using Data for Improvement. My name is Kira Tozer. I'm an engagement leader with the BC Patient Safety and Quality Council, supporting the Patient Voices Network on Southern Vancouver Island.
And I'm Teresa Bissenden, Provincial Engagement Leader with the BC Patient Safety and Quality Council, supporting the Patient Voices Network. We'll be your hosts for this session. This series is specifically designed for patient partners and volunteers who work within BC's healthcare system to help improve care. Authentic engagement with patient partners is not something that happens by accident. It requires planning and well-intentioned principled actions. Inviting patients into improvement work is not a courtesy, but rather something that needs to be done whenever decisions that impact patients are being made. We are dedicated to ensuring patient partners are recognized as part of the care team and as an important part of improvement. We hope that this learning series will provide a deeper understanding of some of the language, methods, processes, tools, and techniques that healthcare teams are using to make system improvements. There are a total of 3 modules in this series, with each module explaining a different improvement topic. This module focuses on measurement and using data for improvement. It emphasizes the importance of collecting data over time and covers how to choose measures for a project and develop a plan to collect data. Your first question might be, what are data anyway? We use data all the time in our daily life and often in improvement projects. Often, we think of data as being numbers, like the weight we see on a bathroom scale, the price we pay for groceries each week, or the number of strokes in a friendly game of golf.
Numbers could be things we count, like number of patients that arrived at an emergency department each day, or the number of errors that caused harm to a patient. Other things we measure. In our daily lives, we might measure daily temperature or the amount of rain that fell last week. In healthcare, we might measure the time that a patient might wait in an emergency department.
These numbers are often presented visually in a graph. For improvement projects, that data is often displayed in graphs over time. For example, the wait time for the emergency room may be plotted every day for the last 3 months.
Data can also be in the form of feedback, presented in words, stories, pictures, or observations. These data are a rich source of information for our improvement work. These data may come in the form of surveys, interviews, audits, focus groups, video recordings, or even just asking people what they think or feel. Whether data comes in the form of numbers, words, or observations, a common feature is that data are recorded and used for learning and improvement.
So, why do teams measure? Remember that improvement is the process of making things better. Measurement and data collection can help improvement teams make things better in a number of ways.
First, data can let an improvement team check the status before an improvement project even begins. What are patients saying about their care? How long are people waiting in the emergency department now?
Teams can then compare what is called baseline data with what patients expect, what external standards like accreditation are out there, or what we would ideally like to see. These initial assessments can also give some ideas about potential goals an improvement team might want to set.
As we mentioned in the previous sessions, all improvements require a change, but not all changes lead to improvement. Data can help teams understand if the changes are making things better or worse, and by how much. Data provides a basis for action and helps teams understand more about their changes. Do they keep doing what they're doing? Do they modify the changes? Or should they abandon these ideas and perhaps try something else? Finally, data can tell us when teams have reached their goals and if those goals are maintained.
An unappreciated yet beneficial effect of measuring and collecting data is that it prompts important conversations about what really matters.
Once we have those conversations and agree on what will be measured, the collected data can facilitate learning and communication amongst team members that has meaning for everyone.
Improvement teams find it useful to use several measures to get insight from a variety of perspectives. Improvement initiatives often have three types of measures. Outcome measures help the team understand if goals are being reached. For example, are emergency wait times getting better? How is our patient satisfaction improving?
Process measures tell the team more about the changes being tried. For example, when a new form or checklist is introduced, are staff completing it? Is it being filled in accurately? We can track data like percentage of forms completed.
Balancing measures tells us if there's anything else that has changed or is different because of the changes introduced. Have there been negative impacts in other parts of the system? Some teams measure staff satisfaction, workload, or finances. As a guideline, 3 to 8 measures are usually sufficient, including at least one outcome measure and one process measure.
Sometimes improvement teams get overwhelmed with what we call the data burden, but there are ways to reduce the effort and still get useful data. As soon as an aim or goal is set, the team can start defining what measures might be needed and how to collect it. Some teams look back in time and gather data from previous months or years.
Teams don't need to measure everything and don't need to measure every patient, record, or interaction to learn. Let's say we have 100 new admissions a month. Surveying all 100 patients requires a lot of resources. Surveying only one patient does not offer enough diversity of perspective. Improvement teams need to decide how to balance the need for data with the resources to collect and interpret that data. The team might survey about 10 patients a month, a smaller sample.
Teams will try to make data collection as easy as possible. Sometimes they can get useful data in computer systems. Other times they may need to add new processes. Teams will also try to collect data in a timely way. Data that is months or years out of date will be less useful. Dr. Donald Berwick once said, if you only do one thing as a result of this improvement stuff, plot the dots. Use time as your teacher. Changes happen over time. Plot your data over time to see trends, patterns, and effects.
That wraps up our third and final module of the Improvement 101 learning series. Thank you for taking the time to learn with us. We hope we were able to answer your questions about measurement and using data for improvement.
This brings us to the end of our Improvement 101 learning series.
Now, at this point, let me say that they speak very quickly, and if you have trouble following the video, you might want to go directly to the YouTube channel that's listed here on this slide, and there you can adjust the speed, and it may be more intelligible and easier to understand. But I thought that was a really good overview of collecting data from the perspective of hospitals who have quality initiatives going on. Now, remember in class 1, I presented the definition of nursing informatics that the ANA had put out. Take a minute and refresh your memory. It's defined as nursing, a specialty that integrates nursing, general science, computer science, and information science to manage and communicate data, information, and knowledge in nursing practice. Now, I think I could revise that definition a bit based on reading and thinking about this and doing it for a long time. I would say that in nursing informatics is a specialty that integrates ethics and philosophy with nursing science, computer science, information science, to carefully select, to manage, communicate, and give meaning to data and information in order to create useful and appropriate knowledge for nursing practice. Would go on to say that nursing informatics is defined by the organization HIMSS, which you can link to, as a specialty that integrates nursing science with multiple information management and analytical sciences to identify, define, manage, and communicate data, information, knowledge, and wisdom. So I have added words that are underlined to these definitions. I've added ethics, philosophy, carefully selecting, giving meaning, and producing useful and appropriate knowledge. And I've added wisdom in these definitions. So let me explain why I did that. There's an article that is posted in your Moodle resources by Chu, written in 2006, where he carefully tracks the movement from signal to data, data to information, and information to knowledge. But on the x-axis, you'll see human agency is a part of this process. And more human agency is required as you move to the right on the x-axis and to the top of the y-axis. So we start out here with signals. We see signals in our environment, and they mentioned some measuring wait time in the emergency room and so forth. And we decide exactly what signal we'll pay attention to and which ones give meaning or sense to what we're about to wanting to accomplish. And we turn those signals through various processes and structures into data. It may be data that comes from the electronic health record. It may be observational data or whatever, but we go from signals to data. But we're increasing our human agency requirement when we move from data to information. Which of these data have meaning for us, and what is the significance of that meaning? And that requires more cognitive structuring still. Here we're just physically structuring our data. Here we're thinking about which data are really informing us of what's going on. Now, from moving information to knowledge, again, we're moving to the right on the x-axis and increasing the human agency, the wisdom, the philosophy, the ethics that go into turning information into knowledge. We are now moving from physical structure to cognitive structure to our belief structuring. And this is a very difficult, high-level stage of knowledge development that started with a signal and created knowledge in the end. But I want to emphasize this because informatics was a word that sort of can be misleading if you think it's information that's automatically going to give you an answer. So I want to now recommend a wonderful article that'll take you deeper and be more thought-provoking than just a couple of slides on this presentation. And it was written by Dr. Terry Jones. And I don't know if you've had Terry here as a guest lecturer, but if not, I encourage you to invite her. She is extraordinary in her writing and communication skills. And she's written this wonderful article about outcome measurement in nursing, imperatives, ideals, history, and challenges. It's written in 2016. It was before its time at that point, and it's still ahead of its time, in my opinion. in thought about informatics. So I highly recommend it. And as I said, it's in your Moodle resources. In that paper, Terry talks about the role of nurse leaders across the entire informatics enterprise. I'll give you a second to read these direct quotes from that paper. And she's making an argument here that nurses have a social contract with the patients that we serve and the populations and the communities in which we are working. And it's that social contract that should go first. We gather a lot of data in informatics that has to do with resource allocation or whether or not to adopt a particular technology or how to deal with accreditation reports that people are asking for. We need data in order to do that. But primarily, that middle paragraph, the quality agenda should accommodate measures related to that efficiency, accreditation and requirements, and value-based payment. But it should be driven by the social contract we have with nursing, because sometimes in our striving for efficiency, we are shortchanging our patients, we are cutting corners, we are missing care, we are not fulfilling our end of the social contract. So I urge you to read Dr. Jones's paper. It is outstanding. One thing she does there that is so interesting to me is she goes back and looks at the history of our attempts to gather information about what nursing actually does. And early on, the American Nurses Association put together outcome indicators, and this is the patient-focused outcomes in this slide here, such as length of stay and adverse events and nosocomial infections and so forth. And those are nurse-sensitive indicators of quality. And here in this column, she tells us how many empirical studies there were that backed up that this was nurse-sensitive. For example, surgical wound infection rates, there really was no empirical study to back that up as being a nurse-sensitive indicator, but it was listed on the report card for nursing. Then she, in this column, says whether or not these empirical studies suggest that there's a causal link between nursing activity and this indicator. And you can see every one of these, we did not have in the 1990s data that would back up the link, but we were still measuring it. Now, in this column, very interestingly, she has listed whether there are data that are readily available that we could use to measure this nurse-sensitive indicator. If you'll notice on patient outcome indicators, there are only 2 that she believes had readily available data on hand that we could have used to create a report card. And even though there are not readily available data here and there are not causal links here, there were still things that we were measuring in the 90s in the nursing report card or the level of nurse-sensitive care. You'll see that decubitus ulcer rates were listed, nosocomial infections, satisfaction with nursing care, the nurse's willingness to recommend this hospital to someone else. So this was her observation about where we began with gathering data back in the 1990s on nursing outcomes. And now we move from patient-centered outcomes to process of care outcomes. And there we have no better and maybe a little bit worse. Remember that this is the third column here is, do we have data readily available? This column is, are there causal links? And this column was how many empirical studies. So we're not really measuring any process of care indicators in the 1990s, except for nursing satisfaction. No, she says we're not even doing that in the 1990s when we began. And now structure of care indicators. So we've looked at patient-centered, process, and now structure indicators. And we see more of those. We can measure some of the things that are going on at the hospital or unit level. The ratio of nursing staff to patients certainly got a great deal of attention early on with Linda Aiken's work. There was data readily available, and it was considered to be part of the nursing report card. There were 2 studies, empirical studies, probably by Aiken, but there was still no definitive causal link to outcomes or nurse-sensitive outcomes. So in this column, you'll see we still had no causal evidence that these were important, but we were measuring them, and you can take a look down the list at those we measured. These ratio staffing issues where data were available were where we focused. We could ask what level of education nurses had. It's another one, whether or not we use temporary nurses from outside agencies, and the turnover rate. So really we had some indicators that told us about nurses themselves, but not much else about the structure in which nursing was carried out. So Terry did start with the history, and I thought that was fascinating. But we move on in time, and we were doing a little better. Here we have the National Quality Forum endorsed measures that were going to measure nurse-sensitive indicators. This came after that first A&A effort. Now we're into a national organization that's bringing together indicators not only from nursing but other places. And these are the ones that made the cut to be included in this evidence here, which came out of the Agency for Health Research and Quality in the United States. So take a minute. Here were patient outcomes, process outcomes, and structure outcomes. And you can see now this table came from Terry's article, but I noticed when I was going over it that she has all of them listed except ventilator-associated pneumonia. It is a NQF endorsed measure, but it was just accidentally left off this table, but you can see it here. So we're improving in the sense that now we're getting more patient outcomes that we're considering patient outcomes that are nurse sensitive, more process outcomes that are not just satisfaction kinds of things, but they're actually, are we doing these things? And they had to do with smoking cessation, or smoking cessation, and its necessary counseling for patients with pneumonia or heart disease. And then structure, we're still measuring nursing mix, but now we've gotten into nursing care hours per patient day, which is more directly related, and a practice environment skill. So not just how many nurses have bachelor's degrees, but what is the environment in which nursing is taking place, and then a voluntary turnover, or another, and that means how rapidly are nurses being hired and then leaving. And that's what we consider turnover. So from the early 1990s to this National Quality Forum set of indicators in 2004, we've made some progress in what we're measuring. But now comes along a tool, and then the second part of what we're going to be talking about is the electronic health record for healthcare, because it opened up so many opportunities that had not been readily available to us early on to get into available data and to begin to build our knowledge about what data could help us to understand about how nursing really did affect patient outcomes. And this is really that electronic health record. Some people refer to it as being part of the fourth industrial revolution. The first industrial revolution in the 1700s was really the harnessing of steam for power. Then in the 1800s, we picked up electricity as a source of power, and that became hugely important in how we organized our lives. And then in the 1900s, when A&A was just beginning to come up with measures of nursing outcomes, the computer was beginning to be used widely. But today, people consider us in this fourth industrial revolution, which is we have connected all of the power of computing and electricity and communication sciences to connect all of our sources of knowledge, which makes us much more able to generate knowledge from the signals that are now in our environment. Many of us are overwhelmed by those signals now, but they give us information which later will lead us, we hope, to knowledge. So the electronic health record really could not have existed before this fourth industrial revolution. Now, I say often in my lab that the data we have, though, is not the data we want. The electronic health record is good, it's got a lot of data, but really I would like to have some more specifics. It isn't enough to tell me the nursing hours spent on this patient. I really want to know what was going on in those nursing hours. But the data we want are not the data we need. We need to know more than just what was going on between the nurse and the patient in the hours he or she spent with that patient. We need to know what other resources that nurse needed but did not have at hand, and all kinds of other questions that we would like answers to, but the electronic health record and staffing information just won't let us get to that. So the data we want from that electronic health record, or that time spent with patients, it's really not all the data we need. But sadly, oftentimes, the data we need are not available. So here are all the data we have now in this fourth industrial revolution. But there's a spot out here that we really need, but we just don't have a way yet to get our hands on it. And I think that's something I want to make sure that we all take away from today, is that it is the nurse leader who has the wisdom to know the steps it's going to take to get down here to the data we actually need, not just to be efficient, not just to be accredited, but to be coming up with our end of the social contract of giving the best care possible to the patients. So here's another just real quick overview of history, the minimum data sets that nursing came up with, and that was my era of graduate school. What were those things that we needed to have information about to know what nursing really was doing? Because all we really had at that time was billing data. The business office had more data than we had about what was going on in the hospital, because they could bill for certain things, and so they kept good records of those, but not as good records of what the nurse was actually doing. Then there was a great movement in the 1990s for the nursing report card, and that's the one we showed you that had the columns where we had very little available data. Then nurse sensitive indicators came on the forefront, and in the 90s and the early 2000s, we had these organizations all getting together and coming up with their own notion of what a nurse sensitive indicator was. NDNQI was a database for nursing quality indicators. CalNOC was a collaborative alliance for nursing outcomes. It was a voluntary group. MILNOD, the Military Nursing Outcomes Database. The military nurses were able to generate information from databases they were keeping. And the VA NOD, Veterans Administration, was there in the United States, the system of healthcare for veterans. They kept their own database. So we had all these different groups trying to come together within their own group to decide what a nurse sensitive indicator was. And then along comes in the mid-2000s, the electronic health record. So that just sort of sums up the history that Terry was talking about in her article. And I put this slide in here not because you're going to be able to read it all right now, but as you go back over this PowerPoint, you can read more carefully the various types of categorical or classification vocabularies that have been developed to talk about nursing care. Clinical care classifications, classification of international classification of nursing practice, NANDA, a standardized classification system for nursing diagnoses, the nursing interventions classifications, NIC we call it, the nursing outcomes classifications, NOC we call it, the Omaha system, a standardized taxonomy to document needs and interventions and measure outcomes, and the perioperative nursing data set. So not only are different groups coming up with what a nurse sensitive indicator is, they're coming up with how to classify processes and outcomes into languages that will express succinctly what needs to be measured to understand nurses' impact on outcomes. So a lot of work going on and a lot of separate, siloed organizations doing that work. So now let's talk about what's happening in Europe. I spent a lot of time now talking about what we were doing in the US, and you all here were doing a lot of that as well. But the European Commission has issued a report in 2019 on the electronic health record exchange format. And that format is going to require that we make some decisions about how we talk about what we do and what we measure, so that what I say I'm doing and measuring is the same as when you say a word, it has meaning to me. We're not using totally different classification systems or vocabularies to talk about our work. And in informatics, it is critical that we speak a similar, if not perfectly identical language. Now, a study was done to see where people were, what countries were in their e-health journey. And yesterday, the first lecture, we went over the history of what Lithuania had been doing. And in the map that you can see on the World Health Organization's website, they had an e-health survey, and Lithuania had done very well in their e-health progress through 2015. And we saw earlier that that was an effort that was supported by legislation and by all kinds of initiatives. So good for Lithuania. You are doing well. You can see some countries in Europe didn't reply at all. Some were still unknown. Some were no, they had not made progress to join a global initiative on e-health, but Lithuania certainly has. Now, we're going to start with a little technical stuff about how to start getting standardization in our communication across platforms, across countries, using electronic health records that when they say they're measuring a particular outcome, it is the same language that's being used in another country measuring that same outcome. So let's start with HL7 and see this short video.
Meet Jim. Jim twisted his ankle playing hopscotch and wants to have it examined by a doctor. When he arrives at the hospital, he registers at the front desk, filling out a form with his name, date of birth, and all his insurance details. Using Jim's information, the Hospital Information System, or HIS, creates a new patient record, and issues him an ID bracelet to wear. After a few minutes, Jim is called into the doctor's office, where a physician looks over his history and dictates some observations using a handheld device. Jim's doctor also wants to conduct an X-ray, so she schedules a time and place using the hospital's Radiology Information System, or RIS. Thanks to HL7, Jim didn't need to fill out separate forms for his ID bracelet and X-ray, and his doctor was able to easily view Jim's chart, add her observations, and schedule his X-ray without the need for time-consuming paperwork. HL7 enabled all these systems to interact with one another, freeing healthcare providers to actually care for the health of their patients. Every time information needs to flow between systems, small text-based messages about specific events are generated and sent. Regardless of whether that event is Jim's registration, the result of his X-ray, or the processing of his billing information, a single message is sent to notify interested departments. HL7 is the language these systems are using to share information. While the language of HL7 is widely used, many systems simply don't know how to speak it. They need a translator, something to turn those HL7 messages, with all their pipes and carrots, into useful information. For this, they use integration engines. These engines work alongside existing applications as an interpreter, speaking the language of HL7. When an integration engine receives a message, it can pull out the important pieces of information and store it in a way the application can understand, like a database or a file. Conversely, when an engine notices a new record or result, it can take that existing information and turn it into an appropriate HL7 message to be sent along to other systems. In the days before HL7 and integration engines, there was no standard method for sharing this data. Systems had to be manually notified, or time-consuming custom interfaces needed to be designed to connect each and every system. Now, thanks to HL7, it's much easier and more economical to connect systems regardless of their original design. Whether you want to connect your HIS, RIS, LIS, BIS, EMR, or any other system, HL7 makes it easy. Not only does that make for a more efficient workplace, it also means better care for Jim.
Now, HL7 is really a formatting language that tells us that in space 1, you will find, space 1 through 7, you will find this information. Then when he says pipes and carrots, he means that in between chunks of information, there will be a straight up and down line, which is a pipe, so that I know how many pipes down the message, where to go to find, say, the patient's age. So it's really programming kinds of language, but it is essential so that you don't have to guess where to look for the information that you're receiving. And it is incredible the benefits that we can get from putting that information in the same location across systems and even within systems, as they're saying, within the same hospital. Now, I just put a little plug in here for what EHRs can do in provider decision-making, because there are systems that, that we use as healthcare providers that are built into an electronic health record, which will also improve outcomes by hopefully preventing error. They can help providers make efficient, effective decisions. They can help us to aggregate information for analysis. And I'll give you an example later on in a case study about doing that. But we're recording all the information on every patient in exactly the same way. And so that becomes very then efficient and easy to pull out reports on patient outcomes, because we know that we've collected the same information in the same way for each patient. There are clinical alerts and reminders that are built into the electronic health record that will help us to not forget something. Support for diagnostic and therapeutic decisions. Sometimes there is a feature of your electronic health record that will say, for this patient range of this lab value, a predictive clinical prediction is that they will then advance to a disease state. There's a 50% chance that they will advance to hypertension, or a 75% chance they will have an MI. So that kind of predictive diagnostic forecasting can also be built into electronic health records. And safeguards against potential adverse events. There are ways that we cannot move forward on a particular task or item until we have done the preceding preventive kinds of work that will keep us from having an adverse event. So it's sort of our outside brain that when we're under pressure and we're working very quickly, this electronic health record can really step up our efficiency, but also just as important, if not more important, it can prevent adverse outcomes if we follow it and have not considered how to do the workarounds that disable it. Now, let's go back here. To talk about the HL7. Here was an example. Sorry, it's a little bit out of order, isn't it? Where the first three letters will be expected to be these identity or ID numbers or letters. Then each section has a code or a variable name or a type. This LOINC is for laboratory work, and the HL7 message for abnormal newborn screening here is the chunk of information on this newborn that has to do with the laboratory tests that were done. And so it looks daunting, but actually it is very useful in that this message will be the same format for every newborn who's screened, so that it makes it possible to quickly, efficiently, and accurately pull information from all the messages, because we know where that information is going to be in their electronic record. So that is a real important benefit of HL7. Now, there's another language or another classification system that we need to become real familiar with, and that is SNOMED. And you may already be using SNOMED and know all about this, but for those who don't, this is an interesting intro.
Hi, I'm Kent Spackman. I'm the Chief Terminologist for the International Health Terminology Standards Development Organization, and I'll be providing a presentation about the basics of SNOMED CT, our clinical terminology. I hope you enjoy it. What we're going to cover is some of the aspects of use of SNOMED clinical terms for clinicians and other users who want to know a little bit more about SNOMED without going into a lot of the technical details. The things we'd like to cover in this short presentation are a little bit about the components and structure of SNOMED CT. We'll say a bit about what post-coordination is, what are SNOMED expressions, and how SNOMED uses description logic. Then we'll talk about the interaction between terminology as provided by SNOMED and the structure of the electronic health record, which is represented by an information model, and how those interact. And then we'll talk about secondary uses of data as distinct from primary uses and how we reuse data. Finally, we'll talk about extensions and reference sets or subsets, and a little bit about tracking SNOMED as it changes using our history tracking and how we cross-map from SNOMED to other terminologies. So this is a brief summary of the building blocks of SNOMED. Obviously, the concepts or the codes in SNOMED are the anchors for the meaning. In addition, SNOMED is made up of terms. These are strings of readable characters used to express the meanings of the concepts in human language. And then the concepts and relationships, concepts and descriptions are linked to each other through relationships. And these are represented in a computer processable language that allows us to have formal logical meanings that can be processed algorithmically. There are a number of other purposes also for relationships. One is to be able to track retired concepts so we know what happened to them and what they should refer forward to in active terminology. Then we may also want to represent facts about concepts that may vary across time. So these are different from the defining relationships. And then we want to be able to support post-coordination by suggesting valid qualifiers. It's important to make a distinction between a code, a concept, a class, and an instance. So when we talk about SNOMED, we understand which of these things we're referring to. Obviously, the code is just a sequence of characters used to represent something in the coding system. SNOMED identifiers are called SCTIDs, or SNOMED Clinical Terms Identifiers. And they're a sequence of between 6 and 18 digits, and they identify the components of SNOMED. Concept codes represent meanings or concepts. So a concept in general is an idea which has meaning. And through its meaning, a person can identify specific instances of the concept. We often use the word class to refer to an abstract category of things that share common features. So dog might be a class, and my dog Fido would be an instance of that class. In other words, it's a particular real member of the class. Or arm is a class. My left arm is a particular instance of that. So we refer to classes and instances. SNOMED codes generally refer to classes. We often talk about them as being concepts, but they're really ideas that have meaning that refer to classes of real things. There is a little bit of internal structure in the SNOMED clinical terms identifiers. The last digit on the right is a check digit. That's used to determine whether there have been changes in the number during transmission or when people copy or paste numbers into spreadsheets or that sort of thing. It's possible to write a program that calculates the check digit and checks to see if it's a valid identifier. The next two digits over really allow us to partition the space of identifiers so that we can identify identifiers that were issued by the IHT-SDO and also identifiers that might have been issued as extensions. We can also differentiate between identifiers for the various components of SNOMED. So concepts, descriptions, and relationships have a different identifier. So you can tell if something is intended to be in a concept identifier slot and it doesn't have the right partition identifier, then there's a mistake, and you can write programs that handle those mistakes in systematic ways. So that's the structure of the SCT identifier. Just to reiterate about concepts and classes, from a formal ontological standpoint, concepts are in people's heads, classes are the abstract entities in the ontology. So sometimes we speak of a SNOMED concept, but what we really mean is the code representing the class, instances of which can be identified by someone who understands what the concept means. So now I'm going to use the word concept when I really mean classes. So what are the types of concepts in SNOMED? FSN here means fully specified name. That's the long name of the SNOMED concepts. And At the very end of each of the SNOMED fully specified names, there is a tag that's in parentheses. And these are the tag names. So they are things like disorder, procedure, finding, organism, body structure. And you can also see the number of SNOMED codes or concepts that are represented of each of these categories. So we have 63,000 and some odd disorder concepts, 45,000 or more procedures, 32,000 findings, 27,900 organisms, and so on. If we look at it from a pie chart standpoint, the largest hierarchies are really disorders, procedures, findings, organisms, body structure, which includes anatomy and morphology, substances, which would be drug ingredients, and products, which would be drugs. So if you take those hierarchies, that represents the bulk of SNOMED CT. And for each of those, we're talking tens of thousands of different codes that need to be organized. So it's a very large terminology. If we look at what you might think of as the values, in other words, the targets of defining relationships in SNOMED, we end up with a slightly different picture. The number of defining relationships that use these hierarchies as values, and in this case, there are 130,000 defining relationships that use anatomy as the target. The qualifier value hierarchy, which is really a hierarchy that collects disparate